Good morning. We're discussing blood film evaluation this morning. And as Heidi said, we're happy to take questions. Feel free to type them into the box as they occur to you, but we will answer those at the end. So first, I'm going to briefly give you the lowdown on blood smears, how to make them, how to scan a slide, and then Drs. Dolan, Mortenson, and Chisler will go through cell lines, identifying normal and abnormal. But first, why are blood films even important? So patients have been started on medications or even referred for thrombocytopenia based on a machine value. And often that machine really is correct. But I think it's important to verify. And I've taken a picture where a patient has a thrombocytopenia of 113,000 platelets. And often that machine can be more egregious, like 40,000 platelets, rather than the 113,000 shown above. But before you panic, look at a slide. To the right, I have some platelet clumps, and those are not read by a machine. So it's easy for the machine to get confused and give you a false value when that's not actually correct. So save yourself some headache if it really is false, and verify before you take any other measures. And another reason to look at a blood slide is egregious white blood cell values. And an excellent example is this case where a patient really did show a monocytosis of 65,000. The normal is hardly over 1,000, so 65,000 really shocked us. So look at the slide and make sure, are these really monocytes? And in this case, they were neoplastic cells that the analyzer really didn't know what to do with and classified them as monocytes. And so it really clued us into what was going on by looking at a slide. And lastly, we had a healthy 1-year-old dog that came in for a fracture repair. There was nothing on the analyzer that indicated that there was any disease process. And I looked at the CBC, and lo and behold, what we found. And after this, the dog did test positive for heartworm disease, but you never know what you might find if you're looking. So now that I've hopefully convinced you how useful blood film evaluation can be, where do you even start? So this may sound basic, but when you're making a blood film, start with clean slides. Avoid using previously used spreader slides for your blood film. Ensure the blood is well mixed. When you leave it out, the blood will separate, and if you make a blood slide based off of that, you'll have a poorly representative slide. And then once it's well mixed, you only need a drop of blood from a crit tube, and you spread your slides at a 30 to 40 degree angle, and you just use really light pressure. If you press too hard, you'll create horizontal lines that will disrupt your blood smear, or worst case, lyse some of your slides. And lastly, but extremely important, your entire smear needs to be on the slide as shown above. If you run off your slide, you know that you've used too much blood, and your feathered edge won't be on the slide, and really your blood film isn't very useful. So there are 3 parts to a blood film: the feathered edge, the monolayer, and the body. And the feathered edge, like we sort of just talked about, is the iridescent part at the very top of the slide. And this is really great for initial evaluation. Heavy things like large cells and organisms often are carried out to the feathered edge, and platelet clumps like to hang out here too. The monolayer is where cells can be evaluated as individuals, like in this picture here. There's white space between the cells, and you can really get a good idea of what the cell looks like. And this is where you'll spend most of your evaluation time. And lastly, the body. This is the body of the slide. It's closest to your drop of blood and is therefore the thickest part of the slide as opposed to the monolayer. Some people include the body in their initial scan. I do, but others avoid it. Be wary of interpretation here. As you can see, the red blood cells are all kind of on top of one another. The white blood cells really become tight and small here. And so be wary of interpretation. You can't evaluate a lot because you can't see a lot here. So now that your entire smear is on your slide and you know the parts of the smear, you can stain it and evaluate. So on 10x, you can scan up and down the slide. You won't be able to assess much this high up. Everything will look pretty small, but you can see any obvious abnormalities, any large cells, anything that catches your eye. And if you do find something, you can go down and look at it closer. But 10x is just a quick scan. You can also see platelet clumps that high up. That being said, you can also evaluate red blood cell density. Here, you can see a lot of white space here in the monolayer. You can get a feeling for if the patient is anemic or not. You can tell if your white blood cells, there's too many of them, if you're worried about an infection or inflammation, or if they look normal to you. And there's no wrong way or right way to scan a slide at 10x. You just do it systematically each time so that you know that you're not missing anything, and you just zigzag up and down the slide. So then after you've done your once through, then you can perform your differential count to decide your percentage of white blood cells. And this is performed at 40x in the monolayer. And you'll count 100 white blood cells. And then whatever number you end up with for each cell line is your percentage. So for example, if you count 50 neutrophils out of 100 white blood cells, then you'll have 50% neutrophils. And then at 100x is where you'll count the number of platelets you have. And you count the number of platelets per 10 fields, and each platelet is worth about 15,000 platelets. So you can multiply your final number by 15,000. This number varies between sources. Some will say multiply by 20,000. There's really not much of a difference there. So if you've been doing 20,000 or you're more comfortable with that, that's fine too. The difference is really minimal. The caveat here is that when you're counting platelets, you cannot count platelet clumps. You can't tell how many platelets are in a clump, so don't even try. You can, at the end, sort of try to quantify how many there are by saying rare, few, moderate, or many, and that can give you an idea when you're sharing your blood value results with someone else that, oh, there were a ton of platelet clumps, so this number may be falsely elevated, or whatever the case may be. All right. Dr. Dolan will talk about red blood cells for a little bit.
Great. So next we'll go through red blood cells, where they come from, what they look like normally, and what we can see abnormally, and go from there. So erythropoietin is the key substance to stimulate red blood cell production. It's actually part of a biologic loop in which low oxygen is sensed at the level of the kidneys, which are what release EPO. Plasma EPO is then rises and stimulates production of red blood cells at the level of the bone marrow. And there are several steps in the process of making a red blood cell, starting with the most immature form named a rubroblast. And there's a few steps in between with some changes in size and color until formation of a reticulocyte, which is the final step prior to maturation into a red blood cell. So reticulocytes are important for identifying the body's ability for regeneration of red blood cells as they're released into the blood prior to the final step of maturation. And so in a normal, healthy animal, the timeline from a rubroblast, or the most immature form of the red blood cell, to a reticulocyte is about 5 days. And then there's 2 more additional days for final maturation. But in an animal that is in a hypoxic state, that can be shortened to 2 to 3 days to produce the reticulocytes. So appearance of mature red blood cells can vary a bit with species. The picture on the left is of a dog, which shows sort of uniform shape and size. You can easily appreciate the area of central pallor, which in the cat, the image on the right, it may vary in size and shape a little bit, and you may see little to no central pallor. So the first thing is anemia, or low red blood cells, and there are many causes of this, including loss of red blood cells or hemorrhage, destruction, sometimes with immune-mediated disease, and then failure of production, either at the level of the bone marrow or due to decreased EPO in production or in circulation. And so for today, we won't get into the details of cause, but rather focus more on the morphologic findings that can help you classify and determine the underlying cause of the anemia. So, so moving forward, we'll talk about how to determine if an anemia is regenerative versus non-regenerative, assessing the size, as well as the color as a surrogate for hemoglobin. So again, red blood cell size is important for identifying underlying disease. On the analyzer, it's reported as mean cell volume, which is a quantitative assessment. It typically is considered better than any one person's set of eyes because it's in the sense that it's reproducible, it's likely more accurate and precise. But when you're looking on your manual smear, the most common cause of macrocytic or enlarged red blood cells would be increased polychromatophils in circulation. As a side note, polychromatophils are essentially the same as reticulocytes that were previously mentioned, but they're simply named differently based on the type of stain that's used. So on the manual blood smears that are stained with Diff-Quick, they're referred to as polychromatophils, which you can see demonstrated in the top image, versus the term reticulocyte is typically used when new methylene blue stain is used, and so that would be the bottom picture. So again, the most common cause of macrocytic or enlarged red blood cells is increased polychromatophils or reticulocytes in circulation, and that tells us that there's red blood cell regeneration going on. There's some other rare causes, and feline leukemia virus can cause a dysplastic or a pre-neoplastic change as well. And as far as microcytic red blood cells or decreased size of the red blood cells, it can be normal in certain breeds. In the case of iron deficiency anemia, red blood cells will go through more cell division so that overall the iron concentration can remain stable, and that causes the red blood cells to be smaller than normal. Microcytic red blood cells will still have central pallor, and that's important when we start discussing other changes such as spherocytes. So erythrocyte color, as previously mentioned, can help assess hemoglobin content, and it's reported as mean cell hemoglobin concentration, or MCHC. Hypochromasia, or low MCHC, is associated with increased reticulocytes in circulation because red cells tend to accumulate more hemoglobin as they mature, and so immature red blood cells would therefore have less hemoglobin carried around. And in iron deficiency anemia, there's insufficient iron, therefore insufficient hemoglobin concentration or synthesis as well. Hyperchromasia, or increased MCHC, is typically considered artifact, and it can be caused by other interfering substances such as lipemia or icterus. So spherocytes are a change that cause the red blood cells to appear smaller, but they actually have normal volume. So in dogs, spherocytes can be identified through lack of central pallor, which again is an important way to distinguish spherocytes from microcytosis or simply smaller red blood cells. But in cats and other species, it can be a little bit more difficult because they may have little or no central pallor to begin with. And spherocytes are really important in identifying immune-mediated disease, and sometimes we can also see it with cytotoxicity. Schistocytes are fragmented red blood cells, and they can kind of be triangular or comma shape, and those are in the top two pictures. They typically indicate physical damage to the red blood cells, and it's usually caused by turbulent blood flow. And they're demonstrated in the top two images, whereas the keratocytes in the bottom two images look like kind of blisters with little horns and can indicate intravascular trauma similar to schistocytes. Eccentrocytes have a crescent-shaped area at the periphery, and it's caused by eccentrically located hemoglobin or hemoglobin that's sort of pushed off to the side. These are typically indicative of oxidative damage to the red blood cell membrane, and therefore they may commonly be seen with Heinz bodies as well, which we'll get to. Acanthocytes have spicules that project from the cell surface, and they're usually unevenly distributed. These are thought to be caused by altered lipid or cholesterol content of the membrane, and they may be associated with things such as hemangiosarcoma, liver disease, DIC, vasculitis, iron deficiency anemia. And so because they're not very specific, it's important to also look at other findings on your blood smear to determine the significance. For example, if you have increased liver enzymes, low total protein, altered synthetic parameters, and you see acanthocytes on your slide, it's something that fits with liver disease. But in an otherwise healthy patient and that doesn't have clinical signs or other findings on their blood smear, the clinical significance may be limited. Echinocytes look very similar to acanthocytes, and they can be very hard to distinguish. The difference is between acanthocytes and echinocytes is the distribution of the spicules. So with echinocytes, the spicules are more uniform in shape and length, and they're evenly distributed around the periphery of the cell. These are typically artifacts with little to no clinical significance, but they can be seen with some drugs, electrolyte abnormalities, sometimes snake bites or bee stings. Ghost cells are empty red blood cell membranes that are formed by lysed red blood cells. So they're simply empty sort of shells of a bit of cytoplasm that are devoid of any functional contents of the red blood cell. They lack staining because hemoglobin typically stains pink, and so because they lack hemoglobin, they therefore are look like that empty sort of shell that the arrows are pointing to. Sometimes this can be artifacts, and the presence of ghost cells, again, has to be weighed against other clinical data and suspicion. The most common pathologic finding we see with ghost cells is IMHA, or immune-mediated hemolytic anemia. So you may observe these with spherocytes, agglutination, or also looking for evidence of regeneration. Other causes of intravascular hemolysis and ghost cells can include oxidative injury, snake bites, or hypophosphatemia, low phosphorus. Codocytes have a bullseye appearance and are typically pretty easy to spot. They're seen with some regenerative anemias, hepatic disease, renal disease, but there's little diagnostic significance because they're so nonspecific, but they're fun when you find them. Heinz bodies result from oxidative injury to the red blood cells, which causes sort of round granules to form at the periphery of the cell as the hemoglobin kind of precipitates out. So sometimes they're not as obvious and they may be just a little bump rather than a full protrusion. And if you're concerned about Heinz bodies, but you're not quite sure, one of the things that can be used as a confirmatory test is new methylene blue stain, which is demonstrated in the bottom picture. And they're commonly seen with eccentrocytes. And you can kind of see the mixture of the two Heinz bodies and eccentrocytes in that top picture because they have similar causes. So things like propofol, acetaminophen, toxicity, onion toxicity, zinc. Howell-Jolly bodies are small, round, sort of dark purple inclusions, and there's usually only one per cell. They're caused by small fragments of the nucleus that weren't expelled before the blood cell was released from the bone marrow. This is generally considered insignificant, but it's important to be able to identify them because they're not to be confused with parasites such as Mycoplasma species, and that'll be covered a little bit more later in the presentation. Basophilic stippling is a sort of numerous small punctate lesions within the red cell caused by aggregation of ribosomes within the cytoplasm. And again, this should be distinguished from parasitism, such as Mycoplasma species. It may be a feature of regenerative anemia, or in a non-anemic patient, lead poisoning should also be on your list. Nucleated red blood cells are most commonly associated with strong regenerative anemias. So they may look different depending on the stage of production they're in before getting released out of the bone marrow. For example, the arrows in the picture are pointing to the most mature stage of a nucleated red blood cell, while the arrowhead is pointing to a more basophilic or darkly purple staining erythrocyte, which is a more immature form of the red blood cell. And then lastly, arrangement of red blood cells on the film is also important. So rouleau is typically considered clinically insignificant, while agglutination is concerning for immune-mediated diseases. Rouleau typically looks like a stack of coins, so that's in the left picture, and can be seen in dogs and cats in a small amount with normal patients without concern. So when there's increased plasma viscosity, the red blood cells don't spread out as nicely, and sometimes it can be indicative of just increased plasma protein. It can be associated with more sinister disease such as multiple myeloma, but again, in a clinically healthy patient, it's typically insignificant. Where in contrast, agglutination is very important finding. It looks more disorderly on the slide. So on the right, they kind of look like clusters of grapes. If you're unclear, you can consider your other findings if there's a regenerative anemia or the patient's kind of clinical presentation that fits with the whole picture. You can also follow up with a saline agglutination test. If it's rouleau, the red blood cells should disperse and kind of break apart because it's based on viscosity, versus true agglutination shouldn't disperse. So next we'll go back to Nicole to talk about platelets.
So to review platelets, platelets are small cells. They don't have a nucleus, and They typically have round to oval shaped small cytoplasmic granules. And you can see some of those little purple granules in the platelets in the picture there. They're normally smaller than red blood cells, but they can vary in size in healthy animals, sometimes ranging greater in size than a red blood cell. And as a refresher, platelet counts can be estimated by counting the average number of platelets on 100x over 10 fields and then multiplying your final value by 15,000. So there are many different causes for thrombocytopenia or a low platelet number, but always remember to first scan the feathered edge and see if you have any platelet clumps that are falsely lowering your platelet value. So we typically think of thrombocytopenia belonging to three causes. One is increased consumption, the second is increased destruction, and the third is decreased production. And your suspicion for cause can be guided by the severity of your thrombocytopenia and additional findings you might find on a blood smear. So increased consumption examples include acute hemorrhage, vasculitis, and some tick-borne diseases. And the degree of thrombocytopenia related to those is often mild to moderate, whereas increased destruction is caused by immune-mediated disease and is typically associated with a really profound thrombocytopenia. It's not unusual to see a true platelet count of 1,000 or less because of the severity of the disease. And then decreased production is due to disease within the bone marrow. And if the bone marrow is affected, we typically see other cell lines, other white blood cell lines affected as well. And then in response to early thrombocytopenia, we can see macroplatelets. And macroplatelets are platelets that are larger than red blood cells, as shown in these pictures here. They're immature platelets that are released early from the bone marrow to try and compensate for low platelet numbers. And on the analyzer, MPV, or mean platelet volume, is measured, and macroplatelets can increase your mean platelet volume, evidence that the marrow really is releasing macroplatelets. However, it's important to remember that mean platelet volume really is the mean. And so if you have a small number of large platelets, it might not increase your MPV, which is another reason why it's important to look at your blood film and assess for platelet size. And I think it's also worth noting here that there is an important inherited condition of Cavalier King Charles Spaniels, where the animals have a mild to moderate thrombocytopenia all the time. And that's because they have fewer platelets, but the platelets they do have are all macroplatelets. And although there's less, their macroplatelets are hyperfunctional, so they have the same clotting times, the same ability to clot as any other dog. And no treatment's necessary, even though the thrombocytopenia, because there's no clinical signs. And we've talked about thrombocytopenia, but what about thrombocytosis, an increased platelet number? Increased platelet numbers can be caused by an inflammatory stimulation. Additionally, the body can respond to thrombocytopenia by releasing more platelets and trying to compensate, and can sometimes rebound too hard and overcompensate too much and cause a transient thrombocytosis. And then just kind of a spurious cause, strenuous exercise and stress can cause epinephrine release, resulting in a mild transient thrombocytosis. When this occurs because of stress or increased exercise causing a thrombocytosis, we typically see increased lymphocyte count as well. And now Dr. Mortenson will talk about white blood cells.
All right, so talking about white blood cells, up first is the neutrophil. It is the shortest living white blood cell. Its half-life is 6 hours, and it takes about 1 week to form. in a healthy patient. In times of demand, however, can take only 2 to 5 days to be released into the bloodstream. Mature, or also called segmented neutrophils, have a similar appearance to the image in the upper right-hand corner. And prior to maturation, the neutrophil is considered to be immature or a banned neutrophil, which is not released into the circulation except for in times of high demand. We'll talk about high demand in a moment, but an example of the banned neutrophil is shown in the lower right-hand corner. There are 3 areas of distribution for neutrophils, being the circulating pool, which hosts the cells that are collected during a venipuncture, the marginating pool, which are the cells that are adhered to the blood vessel for a short period of time. These are not collected during a venipuncture. And there's the storage pool, which is the bone marrow. The details of the different pools are beyond today's presentation. However, it's important to know that these pools exist and that there are differences between each species. For example, the dog has a larger storage pool, so it will release more segmented neutrophils before releasing bands, whereas cats have a smaller storage pool, and you'll see more band neutrophils on their smear at the same period of time in the inflammation process. There's also other changes to neutrophils during inflammation. This is called toxic change, and basically these neutrophils are released before the full maturation process occurs, and because it's accelerated, their process is accelerated. Abnormalities will include basophilic cytoplasm. The cytoplasm will also look foamy due to the vacuoles in the cytoplasm. There will be toxic granules, which are pink or red granules that are in the cytoplasm. And then also Dolly bodies can exist as well, which are rod to linear basophilic staining looking granules almost. But these can also be normal and healthy cats in a small percentage, so be careful when looking at Dolly bodies. There's another neutrophil change that you can see, which is called Plager-Hewitt anomaly. And this is an abnormality that is most commonly seen in Australian shepherds. The neutrophils appear similar to a band neutrophil. However, this is normal in their breed. And this anomaly is very important because it can be confused with a left shift, which is when there's more bands in circulation. So talking about basically the trends of neutrophils, there are 3 ways that neutrophils increase. One being that there's a shift from the marginating pool to the circulating pool, 2 being a release from the bone marrow or the storage pool, and 3, an increased production in the bone marrow. Again, the presence of bands in circulation is described as a left shift, but the left shift can be further classified into regenerative versus non-regenerative, or degenerative, excuse me. And so when there's more bands in circulation than there are segmented neutrophils, this is a degenerative response and it's inappropriate because the inflammation is not being compensated for. And then if there's more segmented neutrophils than band neutrophils, this is an appropriate or compensated response to the inflammation. So then jumping to why neutrophils do increase, they increase due to a variety of different reasons, being inflammation from infection, neoplasia, immune-mediated responses, or even stress on the body. And this will be a mild left shift. And it can also happen in response to epinephrine. This happens mainly in young cats, and it's short-lived, and it's usually mature neutrophilia. And neoplasia can also cause an increase as well, and this will be a severe increase in the neutrophil number. So what causes neutrophils to decrease? There's also 3 reasons or main categories for why they do. It can be from a shift from the circulating to the marginating pool, from egressing into tissues, or a decrease in production, a decreased release from the bone marrow as well. When neutrophils are low, it's called a neutropenia. What causes it is inflammation, usually acute inflammation, gram-negative infections causing an endotoxemia, a decreased production from tick disease, viral diseases, or chemotherapy, neoplasia, and peripheral destruction, usually in immune-mediated responses, as stated before. Next up is the lymphocyte, and these can survive in the body for many years. They are produced in the lymph tissue, such as the lymph node, the thymus, the spleen, and the bone marrow. These can live in the tissues, or they can migrate out into the lymph tissues or into the bloodstream and see it in the peripheral blood. The cells, are shown in the upper right-hand corner. And as you can see, they have a large central nucleus. They have scant basophilic cytoplasm. And they have 3 different sizes, being small, medium, and large. This is important because small lymphocytes predominate in the bloodstream, and occasionally you can see medium lymphocytes as well. There should not be large lymphocytes in the bloodstream in a healthy animal, and if there are, this can be neoplastic. It's important to recognize that there's also reactive lymphocytes, which are activated B cells that are released in times of antigenic stimulation. And these cells are larger, and they have an irregular shaped nucleus, and they have an increased basophilia of their cytoplasm. So what causes lymphocytes to increase? So epinephrine response, similar to how neutrophils increase, can cause lymphocytes to increase, and it's usually a transient response, and again, in young cats. Lymphoproliferative disorders such as neoplasia or FELV can also cause it to increase. Young animals have a normal high lymphocyte count just due to their immune system basically being overactive all the time. And then chronic antigenic stimulation or inflammation. If there's an absence of glucocorticoids or endogenous glucocorticoids in the body, this causes a decrease of apoptosis of the cell and can also cause lymphocytes to increase. For lymphocytes, or what causes them to be low, endogenous or exogenous glucocorticoids is the most common. Can also be due to an acute inflammatory response, or in some cases, a congenital or acquired conditions causing decreased lymph tissue. And next up is the monocyte. Monocyte originates in the bone marrow, and these cells migrate into the tissues where it can be considered a macrophage or a dendritic cell, and it depends on which tissue it migrates to for what it's called, first, like macrophage versus dendritic cell, depends on the tissue it goes to. These cells can survive for years in the body. The macrophage or the monocyte, is the largest white blood cell, and it has blue-gray cytoplasm and variably shaped nuclei, as you can see in the images. The function of the monocyte is to present antigens, play a role in phagocytosis, wound healing, and chronic inflammation. Inflammation, either chronic or acute, stress, or steroids can cause monocytes to increase, and in rare cases, so can neoplasia. However, when monocytes decrease, the number is not clinically significant. Eosinophils have a short half-life, as they only live minutes to hours. They migrate into the tissues where they finish off their life. In comparison to a neutrophil, they're a little larger, and there's species differences as far as the morphology goes. As you can see in the image, the dog has variable granular number and size, and cats have densely packed rod to round shaped granules. And it's important to know that you won't see a lot of eosinophils on your blood smear because they migrate into the tissues. And then basophils, they have a short half-life of around 6 hours. They also migrate into the tissues, so you won't see as many as well and on a peripheral blood smear. In comparison to a neutrophil, they're a little larger. And again, there's species differences. In dogs, they're poorly granulated with a small number of dark purple granules. And in cats, they have a large number of dense gray granules. And their nucleus can vary as well between both species. So eosinophils and basophils tend to increase for similar reasons, which is why we're talking about them together. They increase due to parasites, hypersensitivity disorders such as flea bite and asthma, or flea bite allergy, excuse me, and asthma, mast cell degranulation, neoplasia, and in some cases it can be idiopathic. And similar to the monocytes, when their numbers decrease, it is not clinically significant. And our last white blood cell is the mast cell. They have a long survival time in the body, and they also originate in the bone marrow, but they migrate to tissues. So again, you won't see very many on your peripheral blood smear. And what causes them to increase is neoplasia most commonly, such as lymphoma or mast cell tumors, and inflammation or allergic reactions or allergic diseases, such as dermatitis, enteritis, and pneumonia. And next up is Dr. Chisler with infectious agents.
Let me just get her logged on because she is presenting from home. Okay, Dr. Chisler, if you want to turn on your microphone and video.
All right, can you hear me? Hi, Heidi, can you hear me okay?
There you are.
Can you hear me okay?
Try again. There we go. Now we can hear you.
Okay, sorry, I don't know why my microphone wasn't picking up for some reason.
Nope, I think it was on my end, honestly. So if you're good to go, I'm going to go ahead and mute myself.
Okay, perfect. Let me just. Sorry, everyone. For some reason, I cannot enter presenter mode.
Okay, we can probably present on our end. If
Okay.
you want to stop sharing.
Okay.
And then I will have one of your colleagues advance the slides for you.
Okay, that'd be great. I don't know why the toolbar just kind of ceased to exist.
Just go ahead. Just go ahead and stop sharing on your end.
Perfect.
Okay, just one sec. Okay. Dr. Chisler, can you tell me if you can see this, the screen right now?
Yep, I can see it just fine.
Okay, perfect. Can one of you ladies go for where she needs to be?
We might have to flip through. Is there a way to just go straight to first slide? Yeah. Here we go. It'll be slide 50.
Okay, perfect.
Okay, so, sorry everyone. Heidi and I practiced that yesterday and it it went smoothly, but I am technologically challenged. So thanks for bearing with me. So my name is Dr. Betsy Chisler, and I'm going to be talking about infectious agents that you can see in different types of blood cells. So infectious agents that you can see in red blood cells, white blood cells, and platelets. And I do have a couple cats who might be moving around. I'm trying to keep them away from the computer, but you know, cats and computers, they just, so I apologize if they're meowing or walking past. So the first agents I'm going to talk about are infectious agents that invade erythrocytes. And we're going to talk about two different agents in dogs, so Babesia canis and Babesia gibsoni, and then two different agents in cats, Cytauxzoon felis and Mycoplasma haemofelis. And sorry, Mikayla, for some reason they're animations, so if you want to just like click once, yeah, thank you. So the first agent I want to talk about is Babesia canis. And I guess we can just kind of lump Babesia canis and Babesia gibsoni together. So there are multiple species of Babesia and subspecies, and it gets very complex and confusing. So this is a bit of an oversimplification, but the two Babesia species we're most concerned about in dogs in the United States are B. canis and B. gibsoni. They're a protozoan parasite, so a single-celled organism, but not a bacterium. And the most common mode of transmission is via the brown dog tick. So the tick bites the dog, the saliva of the tick contains the infectious life stage of the babesiosis organism. It gets migrates into the bloodstream and then infects red blood cells. And what happens with these Babesia species is after they invade red blood cells, they reproduce asexually and then they lyse the red blood cells. So they cause a hemolytic anemia. And clinical signs can be variable, but in general, we think about fever, anorexia, pale mucous membranes, and on the blood film, you may be able to see organisms, especially early in the disease. And you should definitely see evidence of anemia if the dog is clinical for babesiosis. Okay, next. So here's an example of a blood film of a dog who was infected with B. canis. B. canis is also called large form or large Babesia, and that's because the Babesia pyroplasms, which you can see here, are larger than those of B. gibsoni, and they usually occur in pairs, or sometimes there'll even be 4 of them in a blood cell. So these are often considered easier to see on a blood film. The next slide has an example of Babesia gibsoni, or the small form Babesia. So as you can see, much smaller, much more subtle. So that can be typically particularly difficult to diagnose, excuse me. As far as babesiosis, it's a complex disease, and dogs can be infected with babesiosis and not be clinical. It can be difficult to diagnose on a blood film, but the reason blood film evaluation is so important is if you do see the organisms, you have a diagnosis. Otherwise, you typically have to send out tick disease panel, often to NC State is usually where we send them, and they can take several weeks to get back. So if we're able to see this organism on blood smear and get a diagnosis right away, it really helps in terms of the dog's treatment plan and outcome. One thing about Babesia is that it can be difficult to see in blood, period, but especially in venous blood. So you actually have a higher likelihood of finding the organism in capillary blood. So blood smear made from an ear prick or like pricking a paw pad, there's a higher likelihood of finding the organism. The other thing that you can do to try to increase the sensitivity of the blood film is to get a hematocrit tube, put your sample in the hematocrit tube, spin the tube down, and then make a smear of the red blood cells and the buffy coat. So the red blood cells closest to the buffy coat and the buffy coat. And the reason is the pyroplasms make the infected red blood cells heavier. And so those red blood cells will be adjacent to the buffy coat in your hematocrit tube. So that can be a way to try to increase your sensitivity and get a diagnosis. So I have some trivia questions thrown in. I might be the only one who likes trivia, and maybe these are obvious answers, I don't know. But my first question is, Babesia canis infection is considered endemic in which breed of dog? And if you type in the Q&A, I can see your answers. I didn't put polls in, but I'll see if anyone answers. Yes, Jennifer, you're correct, the Greyhound. So the Greyhound is particularly susceptible to Babesia canis infection, and they're considered endemic in Greyhounds. Greyhounds are common blood donors because they have really high PCV naturally. They just have more circulating red blood cells than the average dog. And they also have very beautiful veins because they're nice and slim. And so if you're doing proper blood donor protocols, you screen for lots of potential infectious organisms, but Greyhounds particularly, you want to pay attention to babesiosis. Okay, next slide. There's the Greyhound. Okay, so then I have another trivia question. So the other common type of Babesia is endemic in another dog breed, or sort of a class of breeds. And my hint is that the high infection rates in these breeds are believed to be secondary to transmission via dog bite wounds. So I'm wondering if anyone knows which breeds, or kind of our class of breeds, is predisposed to Babesia gibsoni. Yes, Nicole, excellent. Pit bulls, yes. So pit bulls are predisposed to Babesia gibsoni. And especially as we get more rescues coming up from southern states, it's a good thing to screen for. And again, they may not be clinical for the disease, but we do see significantly higher rates of Babesia gibsoni infection in our pitty breeds. Okay, next slide. All right. So the next organism I'm going to talk about is Mycoplasma haemofelis. And this is the causative agent of feline infectious anemia. So sorry, Mikayla, if you click, it'll pull up the info. Thank you. So Mycoplasma is a bacterium, and it lacks a cell wall. It's a very tiny bacterium. And this particular type of Mycoplasma infects cats and causes feline infectious anemia. The actual mode of transmission for feline infectious anemia is unknown. We suspect that cat fleas are responsible for transmission, but there are likely other modes of transmission, but we just don't know for sure how exactly cats are transmitting it to each other. When we look at a blood film, this can be really tough to see. It can be tough to see the Mycoplasma because they're on the periphery of red blood cells. They're tiny, and they're often slightly out of the plane, and that's because they're basically on the red blood cell surface. And so when you usually need to be at 100x to see them, and then you usually have to adjust your microscope so you're slightly out of the plane of the cells, and then they become more apparent. Some other signs that you might see on the blood film that would lead you to be suspicious of this mycoplasma would be, evidence of a regenerative anemia, especially if it's a young cat and it really doesn't have any other cause for anemia. And again, then you'll just see those small basophilic structures on the periphery of your red blood cells. This can also be a tough disease to diagnose because the anemia is cyclical and the number of organisms is also cyclical. So the more organisms, the more severe the anemia, but a cat can be infected and have a low burden, and therefore you're less likely to see them on blood film. But again, this is something where if we can diagnose it on the blood film, we can get treatment started right away, and we can save lots of money sending out either, sometimes if we send the slide out for review, a pathologist can see it, but the next step is a PCR test. So it can be price effective for the clients if we can identify this and diagnose it. Okay, here's just another image. So sometimes there can be multiple mycoplasma on the surface, so they can kind of form little chains, but just another idea of what they look like and how small they are. Okay, so then the other organism I wanted to discuss that affects cats is Cytauxzoon. And this is a protozoan parasite. It is transmitted via the bite of the Lone Star tick, and its reservoir host is the bobcat. So this is not a particularly common disease in Minnesota right now. It's more common in the southeastern United States. But as we, see climate changing, basically the range for these tick vectors is changing, and so it's possible that we may start to see this disease in Minnesota at some point in the next few years. This is a really severe disease in cats, and they develop fever, they develop icterus, and then a very large number of cats die. So it is highly fatal. And then cats that survive the disease end up being chronic carriers. So what we're looking for on the blood film when we're suspicious of this disease is there are pyroplasms in the red blood cells, which are, we'll see on the next slide. And then this is an agent that also infects white blood cells. So you can see these schizonts in macrophages, and these will usually be at the feathered edge of your smear. So the first stage of the disease, basically the parasite invades white blood cells, multiplies, basically causes lots of clots, for lack of a better word. They aren't true clots, but basically the macrophages are so full of the organism that they prevent adequate blood flow and lead to multi-organ dysfunction. But then the next stage, they invade red blood cells and can cause anemia. So the next slide just has an image of what these organisms look like. To me, they look kind of like a ring. So they usually have kind of a circular outline with an area, a more basophilic area. But again, you might see either the schizonts and the macrophages on the blood smear or these pyroplasms in the red blood cells. And then here's just another example. So again, very small, can be easy to overlook, but you can see the pyroplasms in some of the red blood cells on this slide. All right, so we already talked about Cytauxzoon, which can invade red blood cells and macrophages. And then now we're gonna focus on some tick-borne diseases that we see in dogs, and then finally canine distemper virus. And these are all agents that invade leukocytes. Okay, so first we have Anaplasma phagocytophilum. This is a rickettsial organism, and rickettsia bacteria are obligate intracellular bacteria, so they need to invade a host cell to reproduce. And Anaplasma phagocytophilum is transmitted by deer ticks, so it is a disease that we see commonly in Minnesota. Clinical signs are pretty nonspecific: fever, lethargy, anorexia. They can have shifting leg lameness, although that's more associated with Lyme disease, but it's definitely possible. And then on the blood film, one of the most common signs or common findings in dogs with active anaplasmosis is a thrombocytopenia. So about 90% of dogs who are clinical for this disease have low platelets. So that's a big clue that we should be taking a closer look at the blood film. And then the anaplasma organism invades granulocytes, so neutrophils, less so eosinophils, and it forms these morulae, so basically bacterial colonies within the monocyte. So here, this is actually a neutrophil. It's just a degenerate neutrophil, so it's harder to recognize as a neutrophil. But here, these kind of dark little dit dots on the bottom edge of the cell, those are Anaplasma morulae. Okay, next slide. All right, so I wanted to just give you an idea of distribution and prevalence and why looking for these organisms is so important. So this is from CAPC, the Companion Animal Parasite Council. So this is their prevalence of anaplasmosis throughout the United States. So you can see that in Minnesota, we're highly affected. And the next slide breaks it down by county. So you can see pretty much all of Minnesota, high rates of anaplasmosis. The counties that are gray, the data just likely wasn't reported. So this is a very important disease in Minnesota. And if I looked at the data for Washington County, so almost 5% of dogs we test for anaplasmosis test positive. So very high prevalence in our area. Okay. The second rickettsial organism I want to talk about is Ehrlichia ewingii. So this is a very similar bacterium, causes similar disease to anaplasma. They're in the same family of bacteria. The vector for this particular organism is the Lone Star tick. So again, Lone Star ticks, more common in the southeastern US, but we are seeing their geographic distribution move northward a little bit. Clinical signs of this disease, again, fever, lethargy, anorexia, and similar to Anaplasma phagocytophilum, the morulae of Ehrlichia ewingii are found in neutrophils. So you really can't distinguish between an Ehrlichia ewingii infection and an Anaplasma phagocytophilum infection on your blood film. You're just gonna know it's one of those two. And it is treated with the same medication, so the exact diagnosis isn't as important. And here's just another example. So here's a neutrophil, and again, you can see the Ehrlichia morulae at the bottom edge. And then the second species of Ehrlichia that we're concerned about is Ehrlichia canis. And again, rickettsial bacteria that's transmitted by ticks, specifically the brown dog tick and the American dog tick. We don't think of this disease as being particularly common in Minnesota, and our numbers are relatively low, but dog ticks exist wherever there are dogs. And so this is why year-round flea and tick control is important, because these ticks like to live indoors. They like the cushy lifestyle. And so they are a concern even in the winter. This Ehrlichia canis can cause really severe disease. It's kind of beyond the scope of what we're talking about today, but primary clinical signs are fever, lethargy, anorexia. Again, very common in all these rickettsial diseases to have low platelet counts. And then the Ehrlichia canis morulae actually form in monocytes. So here's an example of the morulae in a monocyte. And here's just another example. This one you can see more nicely sort of the individual colonies. But again, not the easiest thing to diagnose or pick up. And then here's a prevalence map of ehrlichiosis. So as you can see there, it's definitely more common in the southeastern United States, but there are cases in Minnesota, particularly as we move animals from the south to shelters here. And then here's just the distribution in Minnesota. So as you can see, we've got higher prevalence in the Twin Cities area, and I think that's most likely due to just rescue dogs coming up from the southern US. Okay, so I've got another trivia question, a breed-specific trivia question. So there's a breed of dog that is at increased risk for chronic Ehrlichia canis infection. So these dogs, they have a harder time clearing the infection, and they can become persistently infected and then develop severe disease later in life. My hint is these dogs are predisposed to lots of other diseases. And Nicole already has the answer. And yes, it is the German Shepherd. So German Shepherds are at increased risk for Ehrlichia canis infection, specifically chronic infection. All right, and then the last agent we're going to talk about in white blood cells is canine distemper virus. So this, not common here, particularly due to our good vaccination programs, but it is seen. The clinical signs: fever, lethargy, nasal discharge, ocular discharge, and then it can progress to neurologic signs. There are some pathognomonic signs, so chorioretinitis, which are these kind of gold lesions in the retina. So you need an ophthalmoscope or a lens to view those. Hard pad disease, so they get hyperkeratosis of the paw pads and sometimes of the nose. And then they get enamel dysplasia on their teeth. Blood film findings, it's very uncommon to see this in clinic at all. And it's very uncommon to see it on a blood film, and that's just because of the nature of the disease and the infection. But you can see viral inclusions in both erythrocytes and leukocytes. And again, this is only during the acute phase of infection. So it's a very short window during which you can diagnose canine distemper. All right. Last trivia question. Can you name any wildlife species that are susceptible to canine distemper virus? Yes, Katie named one. Yes, raccoon. And there is a long list. And so there are lots of wildlife species that can get canine distemper. So everything, it's a particularly difficult, or I guess, what should I say, severe disease in our big cats. So captive lions, captive tigers in zoos have died from canine distemper. Pandas can get canine distemper, skunks, raccoons, foxes, and then some marine mammals, including seals, can get canine distemper. All right, last infectious agent. So our last agent is Anaplasma platis. So Anaplasma platis is, again, another tick-borne rickettsial disease, or this also causes anaplasmosis. This is transmitted by the brown dog tick. So again, not as common here in Minnesota. Clinical signs are fever and then this cyclic thrombocytopenia, so platelet numbers that go up and down. And in this particular disease, you can find morulae in platelets. So here you can see on this blood film, we've got a neutrophil, lots of red blood cells, and then we've got some platelets with these kind of basophilic inclusions, and those are Anaplasma platypus colonies. Sorry, my cat is here. Okay, here's just another example. So again, small, easily overlooked, but worth knowing about. And then this is just a table kind of summarizing all the different organisms we talked about and which cells we can see them in. So this is just kind of for your reference. Okay, and then I just have a few case examples to go over. If you want to put answers in the Q&A, these might be too easy. You guys seem very up to speed on everything, but hopefully they'll at least be interesting. Okay, so the first case example, this is actually a dog I saw as a vet student when I was on my ER rotation. So this is Blitz. He's a 1-year-old male neutered husky. He presented for lethargy and poor appetite. He had a fever on presentation. And on the CBC, he did have a mild thrombocytopenia. So his platelets were a little low. His SNAP 40X was negative. So we did look at a blood film, however, or I should say the techs at the U of M looked at a blood film. So the next slide shows his blood film, not actually his, but this is representative of what they saw. So they would have seen low platelet numbers. And then in these cells, they noticed kind of these basophilic inclusions. So this is actually a neutrophil, again, kind of hard to recognize as a neutrophil, but it has these little basophilic inclusions there. So when we think about diseases in dogs that could potentially form morulae in neutrophils or granulocytes, does anyone have some differentials as to what this could be? So this was actually a case of Anaplasma phagocytophilum. And the dog did test negative on 40X. And that's because it takes 10 days to even a couple weeks for antibodies to form. And so you can get a negative 40X test because there aren't circulating antibodies. And so the ClinPath technicians at the U actually diagnosed this for us because they looked at a blood film and saw the organism in the neutrophils. And so we had a diagnosis and we were able to proceed with treatment right away. The other differential would be Ehrlichia owingii. And again, the specific organism isn't important because we treat them all with doxycycline, but this just illustrates the importance of a blood film. It's inexpensive, and in this case, it gave us as much of a diagnosis as we needed to treat this dog. So the second case is Meatball. So he's a 3-year-old domestic short hair. He presented for lethargy and decreased appetite. He's an indoor-outdoor cat. He had pale mucous membranes on presentation. His heart rate was a little elevated, and he was tachypnic. So if we click, we can see his CBC results. So here's Meatball's CBC. So as you can see, his red blood cells are really low. He's got a very severe anemia. And he does have a reticulocytosis, so it's definitely regenerative. He also has evidence of inflammation. His neutrophils are high, his bands are high. And then he has nucleated red blood cells, which are also supportive of severe anemia. And he has 18, which is crazy high. And if we click again, we can see his blood film. So this is the blood film. This case was actually sent to a pathologist. So this is a case where they had blood work, they pulled the blood, but they sent everything out to the lab rather than taking a look at it in clinic. And if we click again, we can zoom in a little bit. So we see here, got lots of red blood cells, we've got a couple lymphocytes, and then we also have evidence supportive of regeneration, which we have these polychromatophils, so kind of these, there's one kind of in the upper right-hand corner, so a larger sort of purplish red blood cell. And then if you also notice, they're kind of all these little dots in the red blood cells. Most of them are on the periphery. And so does anyone remember, we've got, what our agent might be. We've got a severe anemia, young cat, and little organisms at the periphery of the red blood cells. So this was a case of Mycoplasma haemofelis, or feline infectious anemia. And so this was diagnosed on blood film by the pathologist, and then they did run a PCR test to confirm. There are organisms that can look very similar to Mycoplasma on blood film. But it did test positive. Oh, sorry, people are answering. I didn't see that. It did test positive for Mycoplasma on PCR. So this is a great example of, we could have saved this client a lot of money and gotten this cat started on treatment sooner if we'd just taken the time to take a look at this blood film and to have known what we were looking for. And I've got a final example. So this was actually a case seen at the U of M last year. This was a 3-month-old male teacup Pomeranian. He had been imported from a breeder in South Korea, and he presented to the U of M emergency room for lethargy, decreased appetite, and discharge from his eyes and his nose. He had a temperature of 104.7 on presentation. So the next slide shows his blood film. So here we've got inclusions in both our red blood cells and our white blood cells. So anyone have thoughts? We've got, oh yes, Stacy, excellent. Yes, you guys, this is too easy for you. Yes, this was a case of canine distemper, and it was diagnosed at the U of M on blood film evaluation. So again, just a great example of how such an inexpensive, simple test can give us answers in terms of our diagnostics, and how important it is because you guys are most often the ones looking at the blood films, and so you are very often making these diagnoses. So that's all I have, and I think we're just gonna go back to Heidi and everyone at AERC for questions. But thank you for participating.